All right, so in this video, we're going to be doing assessment and treatment of a patient having an allergic reaction. Again, the scene is already safe. We've already covered our BSI. We know the amount of patients that we have. In this case, it's just one. So all that preliminary stuff has already been completed. So we're going to start with our general impression and work from there. So while this is being filmed in an office setting, we're going to assume that this occurred outdoors, and we'll take it from there. So when I walk up to the patient, I'm going to take a look at my general impression. I see that he's in the modified tripod position. Appears that he's having a little bit of respiratory distress associated with whatever's going on. So what I need to figure out initially is this actually an allergic reaction, or is this a patient that is just having some sort of respiratory distress? Or are they having respiratory distress because of that allergic reaction? So I see he's in the modified tripod position. I see he's having some trouble breathing. I would also expect to see skin color change, a temperature change, a moisture change, which I'm going to assess in my ABCs. But initially what I'm looking for as I walk up is, do I see any obvious swelling, any angioedema in the face or neck? Do I see any obvious hives or anything like that that would immediately draw my attention to an allergic reaction rather than just a respiratory problem? So I'm going to assess his general appearance right now. I've already seen that he's in moderate respiratory distress. I'm going to talk to him. Hey, I'm John. What's going on today?
Yeah, I got stung by something. I can't breathe.
Okay. Do you have a known allergy to insect stings or anything like that?
No, not really, but I've only been stung maybe once before. No problems then, but I can't breathe now.
Okay. So I've already completed AVPU. I know that he's alert. He's able to track me with his eyes. He's able to form sentences and talk to me. While I'm assessing what he's saying to me, I'm also going to assess a portion of his breathing, although I already know he's got an airway because he's talking to me. But I'm going to assess that airway to find out whether he's got any noises. I might expect to hear hoarseness in his voice or anything like that that would clue me in that his airway's starting to swell up. And then I also want to take note of when he's speaking to me, how many words is he able to get out in sentences in between having to take a breath? The fewer words that we see and hear our patient speak, but in between breaths, the more concerning it is for us. In this particular case, he's still talking pretty well, so I'm not immediately concerned, but he does seem anxious that he got stung and he's having trouble breathing. So his anxiety is a little bit of cause for concern, and I want to make sure I'm paying close attention to this as we continue the assessment to find out if this is something I need to treat immediately. Is this a life threat, or is this something where I can gain more information and treat this as we progress through the call? So I want to look at his respiratory rate. I'm looking for rate and quality. What I would expect to see is probably fast breathing, and it may be fast and shallow. One, along with the anxiety, and two, along with the respiratory distress. So I can see that he is having a little bit of respiratory problems and trouble breathing. I'm going to listen to lung sounds, so I'll come over here and I'll grab my stethoscope. Again, we want to make sure we're getting bilateral lung sounds in at least 2 locations. So I'm going to check the uppers. I might expect to hear some wheezing in his lung sounds. And check the bases as well. I've got lung sounds on both sides, which is good, but I do note some audible wheezing. So I'm going to apply a pulse ox to him, see what his O2 sats are. Just going to put this on your finger here, okay? It's going to measure your oxygen saturation in your blood. And with his respiratory difficulty, even though he may be satting fine on here, he's expressed to me that he has respiratory compromise and difficulty, so I'm going to go ahead and put him on oxygen. He's satting right now at 94%, so I'm going to just put him on nasal cannula right now. That way we're not covering his airway in case I need to do some sort of airway maneuver or procedure, and we'll see and gauge if that is acceptable right now. If not, I can either up the flow of oxygen or I can switch masks and put him on a non-rebreather at a higher flow rate. So O2 sat is in pretty good shape. I've applied a nasal cannula. I'll go ahead and start the nasal cannula at about 4 liters, and then I'll move on to circulation. So I want to touch his skin, obviously. I'm going to come down here, kneel down next to the patient, and I'm going to grab his pulse. Especially with an allergic reaction and respiratory compromise, along with the anxiety, you would expect the pulse to be a little bit elevated, which I'm noting now. And I'm also assessing his skin color, temperature, and condition. So his skin looks a little red, and it looks like it's a little pale down past the sting, and up here in the back of his arm where he got stung, I can see an obvious red mark, and it looks like I've got some edema building up in the arm as well. So I can see the site of the injection from the stinger, and I want to see what else is going on. So I've got his pulse, I've got his skin color, temperature, condition. He's a little cool, he's a little sweaty. Also, we would expect to see those with the anxiety, and looks like we've got the workings of a allergic reaction, and we want to make sure that if it does progress into anaphylaxis, that we're ready to treat that, or we just treat it as an allergic reaction if we're not having severe airway compromise. So I can move into the rest of my assessment. I'm going to have my basic partner get a set of vitals for me. So I want a blood pressure, I want an actual pulse, I want a respiratory rate, and I want a blood sugar. And I'm going to work on my OPQRST and sample for this patient. For a couple reasons I want to do this at the same time my partner's getting vitals is if this does progress into anaphylaxis, I want to be able to get the information that I can from him before he's unable to communicate with me. So my partner's getting vitals. I'm going to start with sample. What are you experiencing today?
I'm getting really short of breath.
Okay. Has it gotten worse since you've called us? Okay. Do you feel anything in your mouth or your throat? Do you feel like anything's swelling, or is it hard to swallow at all?
My tongue feels fat.
Okay. Are you allergic to anything by chance? Okay. And you don't take any medications? So the signs and symptoms that he's telling me about right now, I'm very much concerned about the things he's presenting with, and I feel like this is quickly moving into an anaphylactic situation. Are you prescribed an EpiPen or anything like that? All right, so he may not have this problem before. I'm equipped with an EpiPen, and I feel like this is cause for me to administer that EpiPen and get that going so that we can treat this reaction before it gets out of control. So remember, you're going to take the safety cap off of the end of the EpiPen. This is a training EpiPen. You can see it by the orange tip. It's clearly marked as a trainer. And remember, too, that if you can and have time, you can expose the area in which we're going to inject the EpiPen, but in most situations it's cause for just injecting it through the material that they've got. Remember, too, when you're doing this, not to put your fingers over either end. Obviously, the needle is only going to shoot out of one end, but when you get caught up in the moment, sometimes you may grab the wrong end and deploy it. So I just use a closed fist over the EpiPen, and then I will inject it into the outer thigh. That way, all of my fingers are safe, and I'm not going to accidentally inject myself. Make sure, too, that if you can, your patient's still conscious and they're talking to you, let them know what's going to happen. This has a pretty powerful needle. It's still pretty small, but it's going to be a little bit of a jolt for them, so let them know what you're going to be doing. Most patients haven't experienced this before. Sir, I think you're having an anaphylactic reaction. I think your airway's starting to close up. I've got a medication, an EpiPen, that I'm going to inject in your outer thigh, and that's going to help work to reverse the signs and symptoms of your swelling of your airway and everything, okay? Is that okay for me to do? Mm-hmm. All right. So I'm going to inject it on the outer thigh. I'm going to press and hold for about 10 seconds so that all the medication can be administered. Okay, we'll assume that's about 10 seconds, and then I'm going to release the EpiPen. I also want to make sure, since all this kind of happened pretty quickly as I was assessing the patient, if I didn't call for ALS early on in the call based on the information I had when I was dispatched, I definitely want to get ALS coming to me now. So I'm going to have somebody intercept with us and call ALS so they can administer some other medications to reduce the signs and symptoms. And if this further progresses, my EpiPen doesn't work, and his airway gets completely closed off for whatever reason, they've got advanced resources that they can secure the airway. So we'll let a few minutes go by. I've already treated him with the Epi. Hopefully we're going to see a little bit of a change in his anxiety. We can't expect to see an elevated heart rate with this, but hopefully the swelling of the tongue has gone down. Any problems that he's had swallowing is going to start to reduce, and he's going to be able to talk to us in more complete sentences as that starts to work. Another important thing to note with the EpiPen, a lot of times you are going to have to administer a second dose of Epi. You're going to wait about 15 to 20 minutes to do that. But a lot of times with these anaphylactic reactions, the rebound reaction after the first dose of Epi has worn off is typically more severe than the first one. So you want to make sure you've got a second EpiPen ready to deploy in about 15 to 20 minutes if you find that it's necessary to do after your reassessment. So I'm going to continue down my sample. Hopefully my patient's got my vitals for me at this point. I know you're not allergic to anything. Did you say you take any medications?
No, I don't.
Okay. After a few minutes of this, how are you feeling?
My heart's racing, but I can breathe better.
Okay. All right. How's the oxygen doing that I've put you on? Does that feel like it's sufficient for you?
Yeah.
Okay. Again, I'm just going to quick monitor. In most cases, I would just leave the pulse ox on. So from now on here, I'll just leave it on his finger so that I've got a running view of his pulse ox, make sure that it's not dropping or anything like that. Had I had it on when he was telling me that his breathing was getting worse, he was swelling, it's likely that I would have started to see a drop in his pulse ox. Do you have any past medical history that I need to know about that would help me treat you or help me understand what's going on?
No.
Okay, no breathing problems, no diabetes, no asthma?
No, pretty healthy guy.
Okay. You said you've only been stung like once or twice before.
Mm-hmm.
What happened when you were stung before?
I just got really itchy. Took some Benadryl and it was fine.
Okay. Have you ever seen a doctor or anything about bee stings or insect stings or anything?
No,
okay.
I didn't think it was a big deal.
Okay. When's the last time you had anything to eat or drink?
I had breakfast this morning, just some oatmeal.
Okay. And what were you doing when this happened?
Just enjoying some time outside. Something stung me on my arm.
Okay. All right. And how long has this been going on? Today?
I mean, I might have waited a minute or two before I called.
Okay. Did the symptoms of this come on pretty quickly to you?
Yeah.
Okay.
It was definitely different than the last time I got stung.
Okay. Does anything make it better? I know I gave you the medication, but before that, did anything make it better or worse?
No, other than my heart racing right now, I feel okay.
Okay. You sound a lot better. You're talking in complete sentences now. The swelling's gone down.
Yeah.
You're not having trouble swallowing or anything?
Mm-mm.
Okay. The quality doesn't necessarily really apply here. We're not really talking about pain. We know the signs and symptoms that he's exhibited, so we can kind of forgo that. We pretty much know radiation. I'll ask him and see, does he have itchiness anywhere else or swelling, but I know that at the site of the injection from the stinger, he's going to have some swelling, some edema, some redness. Do you have anything else going on? Do you feel itchy right now?
I do feel a little itchy, but it's not bad.
Okay. Where do you feel itchy at?
Like my arm and in my chest.
Okay. So if I hadn't exposed him already, I would expose him. I would either ask him to take his shirt off. If the situation was severe enough, I would cut the shirt and take a look to see if I see hives or redness or anything like that on his chest, on his arms, possibly even in his neck area. Are you in any pain right now?
I mean, where you gave me the shot hurts.
Okay. What about where you got stung?
No, it's just kind of itchy and burning.
Okay. All right. So that answers severity. He really isn't in any pain other than where I gave him the Epi injection, which is to be expected. And we already know time. He said he called about a minute or two after it happened. So add that to the time it took the call to come out and the time we took to get here and on scene. We can pretty much calculate our time from there. So we're going to move into a physical exam. I'm going to reassess my patient based on the vitals that my partner got for me. I'm going to keep a close eye on time, that 15 to 20 minute mark, or if I see a quick and immediate change to his demeanor, I'm going to consider that second round of Epi if I need to do that. My physical in this case, I'm probably going to do a full head to toe on this guy just because I can see on the back of his arm where he got stung by a bee, but I don't know if there's any other places where he got stung. If that insect that stung him got trapped in his shirt somewhere, could provide more stings. Also, if it got trapped in his pant leg or anything like that. So I'm probably going to actually expose this patient completely once we're in a private setting in the back of the ambulance, put him in a hospital gown or cover him up with a blanket, just so I can see everything that's going on because I don't want to miss redness, hives, stings in other places, or the potential hazard that it could sting him again and cause another anaphylactic reaction. So I'm going to do my full head to toe, your decap BTLS, and see if there's anything else going on. Otherwise, I'm going to work towards getting this patient out into the ambulance and ready for transport.